When you take a step back and you look at where we are in the TRK inhibitor space and what we've been able to accomplish with larotrectinib, it's pretty amazing to recognize that even a couple years ago, or even really at the outset of this program, most people in the oncology community would have thought that it would have been impossible to identify a sufficient number of patients to prove that this drug works. And yet this was done in under 2 years from start to finish. And I think this teaches us a couple things. One is that the penetration of next generation sequencing has gotten to the point now where we can be really ambitious in the targets that we pick. And if we can pick targets where the biology is such that the drugs are going to work, that we should not be dissuaded by the rarity of those genetic alterations because it's helping those patients. And what I've come to believe is that if a drug works, we can always find the patients. And I think TRK is the perfect example of that. But there's also kind of a knock-on effect here, which is that as we accumulate these tumor-agnostic biomarkers that drive adoption of testing platforms capable of detecting potentially other tumor-agnostic biomarkers, it potentially creates a snowballing effect where we're profiling more patients, able to identify patients with these rare alterations, and enroll them on clinical trials. And actually, we saw that even at this year's ASCO, where within the space of 1 year, 80 patients were enrolled to a program of LOXO-292, which is a RET inhibitor, and again showed response rates approaching 80% in RET fusion cancers. And so what we're really seeing is an acceleration of the development of these tumor-agnostic biomarkers, and I hope to see that it continues. And I think it's only at this point limited by the biology, is that can we find, how many of these mutations can we find, and can we build drugs which really knock these mutations out?
The ongoing challenges for tumor-agnostic drug development, obviously at the top of the list is regulatory buy-in. Thankfully, we've seen the approval of pembrolizumab for MSI-high cancers of any type, but that is an approval for an immunotherapeutic. I'm very optimistic that we'll see a similar approval for a TRK inhibitor, possibly larotrectinib first in the NTRK fusion positive cancer space, and that's a big win for patients. Beyond that, once the drug is approved, the next major challenge is really getting coverage from payers for these tests in tumor types that historically have no coverage for next generation sequencing. But once those two pieces are in place, I think that these programs like the NTRK fusion positive program have a real utility in terms of helping a wide variety of different cancer patients and bringing them therapies that they otherwise wouldn't have previously had access to.
So I think companion diagnostics are a complex issue. And I'm sure there's others who can comment on this much better than I, but it's fraught with a lot of, beyond just approval for the specific drug, there's a device associated approval along with that companion diagnostic. Ultimately, I think that in the community and in what's being used kind of widespread, ideally, something like a multi-platform NGS would probably be of the easiest way to identify, for example, NTRK patients in the future, if it was widespreadly used. However, again, I think all of this is going to hinge upon, costs and benefit in that cost-benefit ratio ultimately.